I'm really pleased to introduce Dr. Milena Kaufmann. She's one of our child and adolescent psychiatrists. She on the CAP line, and she will be speaking today on autism spectrum disorder. And this is a joint presentation that was created by both herself and Susanne Martin-Herz, who unfortunately couldn't be with us today. Milena?
Hi, thank you for the introduction. It's a pleasure to be here. So we can get started, go over just some of the objectives for today, some of the things to hope to leave you with. That'll be going over some of the core symptoms of autism spectrum disorder, what treatments we have available for these patients, and then just some special considerations when it comes to medication management with this patient population. Next slide. So this is just a helpful visual when we're thinking about autism spectrum disorder. So those two circles in the blue are really our kind of core parts of the DSM diagnosis, the social communication challenges, and what we call our restricted and repetitive behaviors. But there's certainly so many other pieces to that. And so if we look at the lighter blue color, some of the other kind of comorbidities that we're thinking about, anxiety, how it affects mood, some sleep deficits that may be playing a role in how our patients are presenting, some ADHD symptoms with hyperactivity and attention, the irritability, which may be presenting with aggression, some self-injurious behaviors, tantrums, meltdowns. And then on the social communication side, we of course look for any language delays that may be playing a role as well. Intellectual disabilities, and then thinking about things from the medical perspective, things like seizures, any kind of immune dysfunction or deficiency, and GI disorders that we often can see in this patient population. So although there are those two core symptoms and two core kind of circles, there's so much more to think about and assess when we're evaluating these patients. Next slide. So going back to those two core main circles, so the first one being the impaired social communication and social interactions. And so what we're looking for there are deficits in their social emotional reciprocity, so how they're interacting and engaging with others. Looking for challenges in their nonverbal communication, both their use of it and their understanding of others' nonverbal communication, and then difficulty in developing and maintaining relationships with others, with their peers, maybe a lack of interest in those kinds of relationships with others. And then the second bucket and category are those restricted repetitive behaviors. And so what falls within that are repetitive speech or motor movements or mannerisms. We call those our stereotypic movements, or stimming for short. We're looking for certain rigidities that may come out as insistence on sameness, restricted or preferred interests, and then sensory sensitivities, as well as sensory seeking behaviors. Next slide. So some things to be kind of on the lookout for, basically, when we're evaluating kids from a developmental kind of point of view. So we're looking for age-appropriate babbling. Are they responding to their name when they're being called? What does the back and forth interaction look like socially? Are they making vocalizations? Are they having changes that are appropriate in their, in their face, in their affect? Are they using gestures such as pointing? What does their initiation look like? Are they bringing things that they're interested in, like a toy, to a parent and kind of sharing those things and initiating those interactions? And do they engage in joint attention? And what that looks like would be, let's say the child's out on a walk, they see a bird, they point to it, maybe make some sort of utterance, and then look back at the parent while still pointing to make sure that the parent is seeing that object and looking at it simultaneously, because they want to really have that shared moment with them. Next slide. So some things that then might fall as red flags in that first bucket, our social communication, social interaction bucket, would be limited use of appropriate gestures. So are they Are they pointing? Are they using any kinds of nonverbal forms of communication? What is their speech development? Are they babbling at appropriate kind of milestones? Are they developing speech appropriately? Making odd sounds, which would be verbal stims, or those kind of verbal stereotypic behaviors. What does their eye contact look like? And are they having some difficulties with combining nonverbal communication, such as gestures, while also making appropriate eye contact at the same time? What does the play look like? Is it more limited in terms of their pretend play? Are they having difficulty imitating or mimicking parents? Regression is another potential red flag. Did they have some words that they were using in a meaningful way, but now parents are reporting that they've stopped and no longer are using those forms of communication? And then another red flag could be using kind of other ways to try to basically communicate because of, let's say, a speech delay, because of difficulties with using appropriate gestures, or they're not pointing. Are they finding other ways to basically express their needs, such as taking a parent's hand and leading them, let's say, to the fridge when they're feeling hungry? Okay, next slide. So some more red flags, same within that same bucket, but around some of the interactions. So again, when they are interacting, if they are interacting with others, are they making eye contact? Are they having these shared moments where their affect is appropriate? You know, where they're playful, where they're smiling, where they may be, you know, sharing those moments with a parent. Parent is smiling. Are they smiling back? Are they not responding when their name is being called? Are they not initiating, not bringing, let's say, a toy or something that they're playing with or clearly interested in, to get a parent interested and to get a parent to play with them? And are they not having those moments that they enjoy with others? Are they kind of more focused on individual play? Do they not want others to touch things while they're playing with them? And it's kind of clear that they like what they're playing with, but don't want anyone else kind of within their space engaging with them. Next slide. So some examples of some of these red flags.
That one doesn't have anything that pops. Look, it goes. It's for you, Evan. It's for you. Hello. Hello? Oh, you want to talk to Evan? Here you go.
So some things that stand out there in that video, like not making any really significant eye contact with the behavioral technician there, not mimicking, right? She picks up the phone. He's not mimicking that behavior, not really seeing imaginative play, kind of more of this repetitive just banging on the phone, and not too much affect on his face, not a lot of kind of joint attention. So several of those red flags kind of coming up in that video. Next slide, please.
Lydian, do this. Look at me. Very nice. Lydian, look at me, Shauna. Look at me. Look at me. Look. Lydian. Look at Shauna.
So in that video, similarly, we see almost more of like a purposeful avoidance of the eye contact, right? Even though the caretaker is working really hard to kind of get her to focus in on her face, not making eye contact, not responding, right? Not looking back when her name is called. Okay, next slide. And now some red flags in that second bucket for our restrictive, repetitive behaviors. So if you're observing or parents are reporting unusual movement, so again, those might be those stimming behaviors. So some common ones may be hand flapping, certain kind of repetitive hand gestures, jumping up and down, often going around in circles, toe walking can be a common one. So any kinds of repetitive or unusual motor movements. Developing certain rituals or kind of patterns of behavior that are difficult to kind of break within a routine or may cause a lot of distress or meltdowns if things aren't done in a certain order. Becoming hyper-focused on unusual objects that are not toys. So for example, some common ones that parents have shared with me is like a ceiling fan, curtains or blinds, a garage door opening and closing, as well as focusing in on a part of a toy as opposed to the whole toy. So for example, with like a toy car, as opposed to kind of playing with the whole car, focusing in more on the wheels, or opening and closing a piece of a toy, taking it apart as opposed to the toy itself. Having excessive interest or kind of preferred interests that are clear in certain activities, and may be hard to get them to play with other things. Unusual sensory interests, so those sensory seeking behaviors. And then again, the sensory sensitivities, a common one may be kids covering their ears with loud noises, or certain unusual noises like the flushing of a toilet, ceiling fans are some common ones that appear. Okay, next slide, please.
Push. 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 Uh-oh. Uh-oh. Yeah, it fell off. That's right. Here it is. Uh-oh. Go. Push. Good boy. Ready, set, go. You can push. No, stay up here. Stay up here. Go. Stop. No. Nathan. Go. Look, here it is. Here's the train. Stay up here, please. Push. Good boy. Ready, set, push. Go. Push. You can push. Stay here. Stay here. Yeah, it fell.
So if we start with the first brother, I love this video because they're twins and being able to, compare that side to side. So the first brother that is neurotypical, right? We really see that joint attention on the car. We see the eye contact. We see the mimicking. Mom says push, and you hear him making attempts to verbalize push. You see that kind of shared joy and affect, him looking up at mom, smiling, and really kind of sharing the moment, engaged. And then you see with brother, not making that same eye contact, not having that joint attention on the car, or not hearing any verbalizations or attempts to mimic mom, kind of a general lack of interest in the activity as he's kind of trying to turn and kind of get out of the chair and move away. Next slide. So when it comes to initial screening, the MCHAT is available for ages 16 to 30 months. And so the kind of initial process would be the MCHAT, the revised version, and then there is a follow-up for that, the MCHAT RF, the revised follow-up. And doing those together can be helpful if anything comes up positive on the initial one, to go ahead and follow up with the revised follow-up. And then just in terms of some scoring and kind of what to do next. So if the initial score is less than 3, unless there's other things that are standing out clinically or other kind of significant reports, from parent or any other collateral that would make you want to follow up, you can kind of go ahead and pause there and think about what other things might be going on. If there's a score 3 to 7, then it is advised to go ahead and do the revised follow-up and follow up on any of those things that did come up positive. And if that is a score of equal or greater to 2, then it is recommended to go ahead and refer, let's say, to the regional center or to an autism clinic to have a more thorough evaluation completed. And then if the score is equal or greater to 8, then going ahead and getting them into services. So again, something like the regional center so they can start an early intervention program. Okay. So in terms of kind of treatment, so moving along to our next objective, what are some of the treatments available for these core symptoms? So those 2 main core categories, the social communication deficits and the restricted repetitive behaviors. So what we think about our educational programs. So if they are in a school setting, making sure that the IEP service is started and they're being evaluated for that. The goal, of course, is always kind of the least restrictive environment so that the child can access as much of the curriculum, but making sure it's also just an appropriate setting with the right accommodations. Thinking about behavioral interventions, and we'll talk a little bit more about those in detail, but things like early intervention services and ABA, and of course, family support to start doing some psychoeducation with the family and helping them get connected to services and to just other resources so that they are not alone in this process. Next slide. Thank you. So in terms of kind of services, so ABA is certainly, or applied behavioral analysis is certainly one of the most common ones that families will have access to through the regional center and through their insurance. But there certainly are other behavioral interventions that kind of have all stemmed from the core principles of ABA, but we have a lot of evidence for those as well. So some of those are called PRT, pivotal response therapy, the Early Start Denver model, are some examples. And I'm sorry, I see a question popping up. Straight Medi-Cal doesn't cover behavioral intervention per the previous slide. I'm sorry, can we go back to the previous slide and just to make sure that. So there are some services from ABA that will be covered through Medi-Cal through the regional center. So you can get ABA services through the regional center. There are less options in terms of what's available, but it is still possible to have ABA through the regional center for those patients. Okay. Parent training is an important part, and certainly within those behavioral interventions like ABA and PRT, there's components for parent training, so parents can learn those skills. In general, early intervention will include some form of behavioral therapy, and then other things that may be helpful as kids get older, things like social skills groups, and for higher functioning kiddos, we think about individual therapy, things like modified CBT. The other key interventions that are part of the early intervention services are usually speech therapy if there is a speech delay, and then occupational therapy for a lot of these sensory concerns, as well as emotion regulation. Occupational therapy can be very helpful to teach some kind of physical grounding treatments for the child. And again, as we mentioned, thinking about other things like CBT for higher functioning kids. And then of course, thinking about, are there any comorbidities that we can think about for medication management? I think that leads us to our next slide. So currently, when we think about medication management for our patients with autism, there is not evidence that supports treating those 2 specific core groups. So we don't have medications that can help improve social communication. And we don't have a whole lot of evidence for starting a medication that's going to directly treat those restricted repetitive behaviors or sensory concerns. That being said, those two core categories, we can definitely see more challenges with them and more deficits with them if there are comorbidities that may be exacerbating them. So one example of that is the core symptom of the stereotypic repetitive behavior, or stimming. We often see kids with anxiety, or when they're feeling anxious or frustrating, that they will start to stim more frequently, or have kind of really more pronounced stimming. Like, for example, like rocking, they may start almost like a more agitated rocking when they're feeling much more anxious. And although we don't start the medication to treat the rocking itself, we start a medication to help address the anxiety, but often that helps to then reduce that repetitive stereotypic behavior because the anxiety is improving. So we get those improvements in the core symptoms indirectly by treating the comorbidities. Next slide, please. Thank you. Certainly there's more than these three groups for comorbidities, but these are the common ones that we often see and think about. Those are anxiety, ADHD symptoms, and then irritability and aggression. So when we're thinking about anxiety, as previously mentioned, so some of the things that may be leading to anxiety are things like sensory sensitivities, difficulties with transition or changes in their routine, separation anxiety, social anxiety, and certain phobias that can all exacerbate the anxiety. Of course, our first and most important, we want to make sure that they're getting behavioral intervention so that they're connected to ABA, getting some sort of behavioral therapy or some sort of therapeutic intervention. But then when we think about medications, our first line would be the SSRIs. So things like Lexapro, Zoloft, Prozac are things that we think about as first line for treating anxiety. And then some other medications that we consider for anxiety are things like our alpha agonists, the guanfacine, clonidine, and then the use of gabapentin. With ADHD, we have similar symptoms and kind of externalizing behaviors that we do with our neurotypical patient population. So we're looking for hyperactivity, impulsivity, and inattention. Again, making sure that the right type of therapy is there, things like parent management training. And then we think about the same types of medications, so stimulants and non-stimulants, and thinking about supplements like fish oil. Then with irritability and aggression, so oftentimes that looks like tantrums, meltdowns, screaming, yelling, self-injurious behaviors like hitting themselves, biting themselves, head banging, and then of course aggression towards others. And the way that we think about treatment for that is identifying, does the aggression fall under mild to moderate, or does it fall under severe? With mild to moderate, we want to again rule out, is there any anxiety or ADHD that's the main kind of underlying comorbidity that then is leading to aggression, and then treating those appropriately with either the SSRI or the stimulant, non-stimulant. And then some other evidence that we have for treating aggression is with the use of propranolol, and then the supplement NAC has shown some evidence for some self-injurious behaviors. If the aggression is severe, then we do think about our two antipsychotics that are FDA approved, and those are Risperdal and Abilify, to treat the behaviors. And of course, with the goal of always kind of reevaluating and seeing if they can come off of those medications at some point. But if the aggression is severe and there are safety concerns, we do use that group of medications. Okay, next slide, please. So just some things to consider when using medications with our patients. My main motto for our patients is to start low and go slow, because unfortunately they are more sensitive often to medications and experiencing side effects, including sometimes having these paradoxical or opposite reactions to a lot of our medications. If sleep is an issue, that's a good place to kind of first start and optimize that, because of course, if they're not sleeping well, their behaviors during the day will all be amplified with a lot lower frustration tolerance, a lot more meltdowns and tantrums. So thinking about melatonin as a first line, and then an alpha agonist as a second line there. When we use SSRIs, so one of the concerns and one of the things that I'm monitoring closely for is this side effect of activation, which can certainly happen in non-ASD kiddos as well, but we do see it quite often with our patients. And that will look like that kind of opposite reaction. So instead of them feeling calmer or less anxious, we may see worsening anxiety, worsening aggression, increased hyperactivity. And so again, we start low and go very slow with these medications to try to prevent this side effect or catch it as soon as it starts. When thinking about Prns for anxiety and aggression, we do have the option of things like hydroxyzine or benzodiazepines. I do usually start with the hydroxyzine first before thinking about the benzodiazepines. And again, monitoring, because this is a group of medications, both Benadryl, hydroxyzine, and the benzodiazepines, that these patients can have these opposite reactions. And so I do often coach parents to go ahead and trial the medication at home when their child is calm for the first time, because I don't want them trying it, let's say before like a medical visit, if that's kind of what we're using the PRN for, and then giving it to them, having that opposite reaction right before they walk into your office for an appointment would not be the most helpful, or, you know, the first time before they go on a plane flight, things like that. So having them try it at home can help to make sure that they're not having this reaction and to help figure out the right dose that will help for the PRN. When we think about stimulants, they may be more helpful with the hyperactivity and impulsivity piece in our patients than the inattention piece in comparison to neurotypical. And the reason for that is that the inattention may not be stemming from the ADHD. So for example, we talked about some of the red flags, like a child not responding to their name. So for a parent, they may be reporting it like they're not paying attention to me. I'm saying their name, they're not responding. And so that inattention may actually be part of that core piece of autism. And so they may not see that same improvement with the stimulant. And then, oh, thank you. And then just one last point here, or I'm sorry, two last points. One is, in general, when it comes to the stimulants or the non-stimulants, that I'll often start with an immediate release before switching to the extended release, again, just to monitor for side effects. A lot of our patients are not verbal or have limited verbal skills, do not report, even the ones that are verbal often won't share if they're in pain or discomfort. And so starting with that and making sure that they're tolerating it well can be helpful before switching. And then in general, the way that I frame medication management to families is that it can help to decrease the intensity of these symptoms, but the medication cannot help to change the behaviors. And so it's really a package deal with the behavioral therapy, and that they go best hand in hand. So even if we're starting medication, and making sure that they are getting the right behavioral therapy and services. Okay. Thank you. And then here are just some resources that we'll send out after. So of course, the regional center, Autism Speaks, has a lot of really helpful things like using like a visual schedule, resources for how do you get your child prepped for a medical visit or a blood draw? Lots of different helpful resources on there. Sesame Street, for when parents want to have a discussion about autism, they can be helpful to watch videos with their child. I put the link to our autism clinic and the link to our resources. And then as well at Stanford, they have a program called Early Support for Autism, the ESPA, and they have a lot of resources on there as well that can be helpful for parents. Thank you. And then here are just some more to learn more in terms of resources. Autism Navigator is helpful. And these are sometimes helpful to share also, like with parents, just kind of giving specific bullet points or information for certain questions. Interacting with autism, the CDC has a lot of helpful training modules on it. And then the DSM criteria is linked there as well.